And here we go. All right, so welcome everybody to this new webinar. I'm going to introduce the speakers. This is a webinar that talks about neuropathy is big business, and we're going to figure out what kind of business you guys are in. I'm Dr. Joe Dodaro. Just below me is Dr. Greg Hipskin. Doc, what is your exact title here at Inlight Medical?
Well, Joe, I am the medical director for Health Med here, based in Dallas currently.
That's right. Dr. Greg is a MD, PhD, a clinical neurophysiologist, as well as a neurologist with an extensive background in family practice. And he is humbly known as the world leader in brain imaging. Well, I could say that. You can't, but he is. He's way up there in the things that he does.
I do a little bit of that. I don't know. You're being too.
Well, when they do, look him up. And then below, I have my partner in crime, Dr. Matt Dodaro. He's in Atlanta right now, and we're going to talk a little bit about the business of neuropathy. And neuropathy pain, it's big, it's growing, and it's underdeveloped. Neuropathy pain is one of the most common types of pain, but it is often under-recognized and undertreated. Now, Dr. Greg and I were reviewing these data here, and they tried to tell us in this 1998 formula that there was going to be around 600,000 cases of diabetic peripheral neuropathy. And we said, well, that's not kind of strange. And if you look at it, it really pales, that 600,000 really pales when you look at neuropathic low back pain, okay? Because it does exist. So I went and looked at it a little bit deeper, and the CDC says that 9.3% of the population, that's 29 million people in the United States, have diabetes. And if you looked at it, 1.7 million people aged 20 years or older are newly diagnosed in 2012. So we understand that every person with a diagnosis of diabetes has neuropathy. Maybe it's underdetected, maybe it's underrecognized. But the CDC explained that more than 25 million have diabetes, and 1 in 4 of these people don't even know it. So if you think about it, it's that was up from the estimated 26 million that the CDC reported. 1 in 4 people doesn't even know they have it. How are they going to know if they have diabetic neuropathy? Now listen to this. On top of the 30 million, 29 million people who have diabetes, 86 million adults, more than 1 in 3 U.S. adults, have pre-diabetes. And 30% of people with pre-diabetes will have type 2 diabetes within 5 years. What does that say, Doc?
Well, basically what that says is, as we know, the damage to nerves occurs chronically and progressively with elevations in blood sugar, such that even with pre-diabetes, you're already beginning to get nerve damage, such that by the time you get a formal diagnosis of diabetes, the nerve damage has already been underway.
That's correct. So we have 100 million people just in the United States with some degree of diabetic neuropathy. So we looked about that. Matt, where do we rank in the world of healthcare, and how about medications that we're taking? Go ahead.
Well, I mean, we're from 2015 World Health Report, we are 37th, right behind Costa Rica. And the staggering statistic that I can't believe is that we, as the United States of America, we take over 75% of all medications produced in the world.
Well, why do Americans spend so much on pharmaceuticals, Matt? Well, yeah, we know that it's the direct marketing. The United States spends almost $1,000 per person per year on pharmaceuticals. That's around 40% more than the highest spender, the next highest spender, Canada. That's 40% more, twice as much as any other country. These are staggering numbers if you go across the you know, per user, price per user. Let's just say what would be a good country. Switzerland's a rich country, right? They've got money. They spend less than $600. We spend almost $1,000. And if you looked at the pharmaceutical spending per person and their growth rates, from 1995, we went from spending almost $400 per person to almost $800. We show some of the highest growth rates still.
Well, Dr. Joe, if I could just add on what you're talking about here, if you look at those statistics there, $234 billion, and then the second place spender is like 10 times less, United Kingdom, right under us, or Germany.
Yeah.
The reason for this is, and Dr. Matt alluded to this, and that is the direct-to-consumer marketing. There are only 2 countries in the world that allow that, and that is the United States and Australia. And in those countries where you have direct-to-consumer marketing with all of the media, what you have is a culture developed amongst patients of seeing themselves, learning about medications and going to their doctors and demanding a pill. So, for example, myself, as a practicing neurologist, I would often see a patient who would come in and say, "Doc, I've got this pain," and the next words out of their mouth are, "What pill should I take?" Our country, the people in our country, have been taught and educated through overwhelming media bombardment that the only way to take care of a problem is with a pill. I just want to add that.
Yeah, thank you for that insight. Well, and hear about this. How about the percentage of the population reported not filling a prescription or skipping a dose because of cost during the previous 12 months? How about that, Matt? 23% have not been able to fill or even take a dose. Which we have more drugs, we buy more drugs, and they're so expensive for us, we can't even continue with our prescription.
That's a perfect example is, patients cannot afford to fill them. They get 12 new prescriptions per year. And, unless they live in Canada or Mexico, our neighbors, they can't afford to fill them.
So, and I think that, Joe, that if I might add on that same slide there, that the top 2 countries, again, in terms of the cost, the rate that are missing, I don't think it's an accident that the only 2 countries that allow direct-to-consumer marketing are also the top 2 countries where the patients can't afford to buy the pills that they're being marketed.
And the percentage of a population reporting the out-of-pocket expenses for prescriptions of $1,000 or more in the past year. Look at this. If you have no chronic conditions, which is the white one here, and you live in the United States, you're still at 7% of our population is going to spend $1,000 on prescriptions. Look at this. 23% of the population is spending $1,000 per year. More, right? So far above these other countries. Diabetes is an awful toll, quietly emerging as a crisis. This is from the New York Times. And this is what these are the population. This is what we're offering to this patient who has already had an amputation. This is our country. And you were saying, Doc, what kind of disease is this?
This is a McDonald's disease. Yeah. Fast food, we work harder, Americans, than any other industrialized country in the world. The average work week is greater than any other industrialized country, and the days off are fewer. There's a lot of stress, a lot of pressure. Working moms that can't take time to shop and cook good foods, and so what we do is we're channeled into fast food places that are terrible nutrition for us.
Yep, it's just considering that the diabetic population in the U.S. and associated manifestations of the disease, including neuropathy and neuropathic pain, will continue to be among the most rapidly growing patient populations. This is the drug company. And what we're saying is, what if we had a study on 152 diabetic patients that were average 64 years of age, and they had a 56% reduction in their pain in just 6 weeks of care. Now, Matt, you used this study. This is part of the study that you did. What else did you find when you saw these people? Not only is there a significant from in the 8 to almost a 3 in their pain, what else did you find?
Well, I've got some background noise here right now, Joe, but I don't know if it's coming through. But we saw that they cut their pain in more than half, and they were able to have 20% more sensory feeling in their feet bilaterally through the Toronto clinical scoring system that you developed or modified.
So they had reduction in their pain and their nerve function went up, and at the same time their restless leg syndrome went down. And this is using state-of-the-art technology that we apply right to where the problem is, right where there's something. So we have a solution that's not drugs. But what happens if you go what happens if you go to your primary care doc? What happens to them? What are they going to do, doc? You were primary, you were in the trenches.
I can tell you exactly what people do. They have a problem, they have a pain, and they come to the doctor because they've been conditioned to it with the direct-to-consumer marketing. They come to my office and they say, Doc, I got a pain. And as I alluded to earlier, that really the next words out of their mouth is, what kind of pill can I take to make this go away? That's what happens. And
they're being prescribed for a long time, Neurontin and then gabapentin and now Lyrica. Now, this is a great slide, to look behind the curtain. In 1994, Neurontin was launched by Werner Lambert division in the U.S. as an adjunct therapy for the treatment of partial seizures or epilepsy. And you can see from 1994, they really didn't do much sales, but in 2002, the U.S. FDA approved it for post-traumatic neuralgia in a very small study with 563 people. And the next year, look at that, Neurontin loses its patent for exclusivity. But they were making $2 billion. No, 2 in millions. That's in 200 million. That's a lot of zeros, Doc.
Yeah, $2 billion, Dr. Joe. Yeah.
So they made $2 billion a year, leading up to the losing their patent, right? When they had a generic launch of their Neurontin. So this is a clear path for other drug manufacturers to follow.
And I think this slide does point out something else about the pharmaceutical industry. As you can see, they lost their patent in 2003. So the year before they go off patent, they do a very small study and get another indication for Neurontin.
The post-traumatic neuralgia.
Right. For post-traumatic neuralgia, as opposed to just epilepsy and partial seizures.
Well, what else happened was in 2004, there was a landmark healthcare fraud prosecution against Pfizer, the world's largest pharmaceutical company, where it agreed to plead guilty and pay $430 million in fines and settlement charges in a case involving its Warner Lambert unit, flouting the U.S. federal law by promoting non-approved uses of one of its drugs. Now, we saw that it was approved for partial seizures. We saw that it got an okay for post-traumatic neuralgia, but what were the majority of people taking Neurontin being prescribed for?
Diabetic neuropathy.
And that's called off-label prescription, right?
That's correct. They were using it for an off-label indication. They felt that it was helping, although they didn't really have a lot of data for it. And they made a claim that was not approved. And you can't do that with the FDA. Medications are approved for specific uses. If you use it for something else and make a claim, then that's false advertising, which occurred.
So $430 million. All right. Well, they went to the whistleblower, and then a lot of that was shared with the other companies. But look, they made that in 1 year. What do they care, right? When you're making $2 billion. So, of course, they pleaded guilty, but they were giving the drug and getting Americans working on a drug that wasn't even approved for that. So when you look at the global market of Lyrica, all right, it's $925 million in 2006, increasing to $2.4 billion by 2010. And this is because it's a fraction of the sales that Neurontin would likely have posted in 2004 had the generics not been launched. So they came in right behind them. The generics took the money, but the pregabalin, which is the Lyrica, did have the indication for diabetic peripheral neuropathy. And Matt, you know about that word, diabetic peripheral neuropathy. Tell me about that.
Well, I'll tell you what, these guys were smart because in 2013, they spent $250 million to copyright that phrase. And they've got Cedric the Annotator as their spokesperson. You see him on commercials.
Yep. And so they did pretty good. They did pretty good with this thing. So when you compared Neurontin to Lyrica, or the pregabalin, all right, they did get an indication for diabetic peripheral neuropathy. They own it. And when you looked at it, yeah, it had weight gain and peripheral edema. And it's look at the difference. If I took Neurontin, all right, which is not the generic, right? Or it is the generic.
Neurontin is the brand name. Gabapentin is the generic. Yes.
Okay. So if I take the regular brand, I'm going to spend between 30 cents and $2 per prescription, per dose, cost per day. Now, if I take the Lyrica, right, the new one, I'm going to spend maybe $5 a day in cost. So it was good business for that pharmaceutical company. Now, I went to the strongest evidence possible, and I want to review these with Dr. Greg here. The Cochrane, these are the Cochrane reviews. These are the highest trusted evidence, informed decisions. This is the highest level of science to see, is gabapentin good for chronic neuropathic pain in adults? The bottom line, there is moderate quality evidence that oral gabapentin at a dose of 1,200 milligrams on more or more has an important effect on some people with moderate to severe neuropathic pain after shingles or due to diabetes. This means what? It means that in pain after shingles, 3 in 10 people had pain reduction by half or more with gabapentin, and 2 or more with a placebo. So they're telling me that you had to treat 10 people with $5 a day dose every day to have 3 people get better. And if you gave them a sugar pill, you had 2. And then that's all they say, 30% better from the drugs. But that's bad math, okay? So pain was reduced by a third in 5 or 10 people. That's the 30% number. And 3 in 10 people with placebo. And that's from shingles, right? In pain caused by diabetes, 4 in 10 people had pain reduced by half with the gabapentin, 2 or more in placebo. And pain was a third or more in 5 of 10 and 4 of 10 with placebo. So placebo was almost as good as gabapentin, given it there's 1,200 dose. There is no reliable evidence for any other type of neuropathic pain.
And I think the key point there on that slide is that even if for the small percentage that got better, they only got a little bit better, and they paid a whole lot. And then later on, I know you're going to show us some side effects, what the downside is of those medications, Dr. Joe.
Yeah.
So
the side effects,
not very impressive. The bar, the threshold for being approved by the FDA is very, very low, and the adverse events profile more than offsets that minimal gain.
You know, Dr. Greg, you make a good point. You know, our whole life we hear about the stringent FDA approval guidelines, but this past election we realized one thing. For every dollar spent on research, pharmaceutical companies spend $19 on marketing to our families and the consumers.
That's correct.
And I like to say that instead of showing us a picture when they're marketing to us of people walking through the flower gardens and throwing the kids up in the air and sitting in a tub in the middle of a field, which we don't know what they're advertising, they should explain that. They should show a picture of the side effects, right? Like the common side effects of, bleeding out of your ears, vomiting, death. I mean, these are the things. So there was more side effects in the drug group than the placebo group, because the placebo group gets side effects too, but dizziness, sleepiness, water retention, probably walking occurred in about 1 in 10 people. Serious side effects were not uncommon and not different between the two, but slightly more people taking gabapentin stopped taking it because of side effects.
I think to point out on that dizziness problems with walking in this population of middle-aged to elderly people that have balance problems and dizziness problems, that can result in falls. The disease itself causes you diabetic neuropathy with the numbness, causes you to have balance problems in itself. And then the treatment adds to that such that you're doubling your risk. And then what ends up happening is, what I see in my practice, was these people end up with broken hips, falls, subdural hematomas, and death from some of these side effects. So you got to weigh it's always in medicine, as you know, is a cost benefit analysis. What is the cost in terms of the dollar cost and the side effect cost, the cost of the side effects versus the potential benefit? And from the data you've shown so far, the benefits, 3 in 10 versus 2 in 10, 5 in 10 versus 4 in 10 kind of a benefit. I know you're going to show us that not only the cost of the pill itself in dollars, but the cost in terms of side effects. You have to weigh those when you make a decision as a clinician, and I know you both have had those decisions. What is the cost to benefit ratio?
Correct.
That's right.
And it's very high in the case of these medications.
You talked about the balance problems and the falls, the risks of falls. I love one of our stats from Neuropathy Treatment Centers of America. 60% of your balance comes from your feet. And these patients, they lose such a little bit every decade of life that, they don't realize. Next thing they know, they have a cane and then a walker. And it's not the fall that kills you, it's the pneumonia and being in the hospital, from the hip replacement.
Well, that's right. If the fractured hip doesn't get you, the pneumonia will. That's a true statement.
And then people will go to a neurologist to have more tests and more medications and more of the same, and they may try different ones like pregabalin, right? This is the Lyrica, right, Doc?
That's right.
So pregabalin has been used as an antiepileptic to treat these diseases, and only a minority of patients with these types of pain will have substantial benefit, or somewhat more will have a moderate benefit by taking these pills. So pregabalin, it says here, post-traumatic neuralgia, complications of diabetes, and fibromyalgia, only a minority of patients with these types of pain will have substantial benefit, and somewhat more will have moderate benefit. So at 300 to 600 milligrams, the potential global impression of change rating of much or very improved was about 35% in the post-herpetic neuralgia and 50% in the painful neuropathy and 40% in fibromyalgia, okay? So basically what they're saying is that you had to take this much to have a 50% change in their diabetic neuropathy pain, very similar to the results on the natural healing. And there is no evidence for pregabalin is effective in any acute conditions and in chronic conditions in which nerve damage is not the prime, such as pain, such as neuropathy, arthritis.
If I could add one thing, one of the things, and I'm sure you're going to cover that in one of the next slides, but since we've been doing our campaign and our public service campaign to get out and speak to the community, we've talked to over 1,000 people over the last 13 months. And I've had probably a dozen women come up to me and say, when I was taking that Cymbalta or the Lyrica, I had suicidal thoughts. I had to stop. And it's much more common than you think. And, it's just, I'm sure you'll pick it up.
Yeah, that's a good point. And certainly that is one of the side effects. And there are many side effects that any responsible clinician needs to evaluate the cost side of the treatment paradigm versus the possible benefit. So what we've laid out here so far to this point in the talk is the fact that these pills have some minimal effects, but they have significant side effects and both dollar costs and side effect costs that have to be put into the formula.
Is a drug used to treat your depression and urinary inconsistency, and it's also helped for certain pains. So it's damage to the peripheral nerves and stuff like that. But what they said is that there is moderate quality evidence that duloxetine reduces pain in fibromyalgia, and a 50% or better improvement was just about 1.5 times more likely than with placebo. So it's still 1.5 times is still not even, that strong. And so on the single case study, it's not possible to determine if any of this stuff is very good for fibromyalgia or even peripheral neuropathy. Okay. It's just not cool. And when you look at the baseline studies of treating placebo, changes between baseline pain and placebo pain versus changes in the gabapentin type of pain, that's really minuscule. It's not significant between these two pain things, right, Doc? Of course, if you keep adding other drugs to them, you may have a greater decrease, but most of the time, it's very similar to placebo, right, Doc?
Well, yes. If you look at the baseline there at 5.72, that's how much pain people rate themselves when they come in. It's pretty high on a scale of 0 to 7. Taking a sugar pill cuts you down to 4.49, but then adding an expensive medication like gabapentin with all of its side effects that you have on the other side is a really minor benefit. Now, if you just switch from that gabapentin over there to the adverse events and look at constipation, sedation, dry mouth, dizziness, cognitive dysfunction that result often in the dizziness that results in falls and things, you really have to understand that you have to plug in the adverse events. Now you look at morphine. No one denies that morphine relieves pain, but it's got serious side effects. For example, the so-called opioid-induced constipation. I had one patient that was on morphine for a chronic pain condition that was not a neuropathy, and they ended up being constipated, and that sounds benign, but it's not. They had to strain so hard at their stool that they ruptured one of their heart valves and died. So some of these, side effects have to be taken seriously.
When we looked at the efficacy of pregabalin in post-traumatic neuralgia, you see that the same numbers, Doc, to have a 50% responder, you had to take, the number of patients was 40% of the patients taking this dose a day, right, 300 milligrams a day. They had a less than 40% had a 50% reduction. A placebo had almost 10%. And at 30% responders, all right, there's really no difference. And we had almost 20% of the placebo group. And in our study here that Dr. Matt did, we had 50% reduction on average of the pain from this group. And these were diabetic patients who had strong neuropathic pain, rating as an 8.
And Joe, we see that across the board. Over 9 years of treating patients here in Atlanta, that VAS, that visual analog score, the patients come in with an 8. And 0 being no pain, 10 being unbearable pain, take me to the emergency room. These people who are our spouses, our parents, our grandparents, they're living with a pain level of 8. And it's like Chinese water torture because your nerves never sleep. They never rest. And, this is what's so debilitating about this disease. And I'm glad to see that our results are better than gabapentin and Lyrica.
So the reality of – go ahead, Doc.
Yeah, and if I could embellish upon what Dr. Matt has said, not only your results, your direct results better, you're, in terms of the cost-benefit ratio, what were the side effects of your light therapy? What were the adverse events? How many people had to stop or had a complication or a fall from putting that light pad on their foot?
That's right. No side effects that we noted, Doc. That's great.
What is the denominator? Cost over cost over risk, or the risk over benefit. What was the risk of using your light, Dr. Matt?
The risk was they started feeling their feet again. It was a good side effect, and that's what we like to see.
Well, in other words, what I'm trying to exaggerate and make the point here that the risk of using the lights is zero. Zero side effects, zero adverse events. I don't believe you had anybody not stop their treatment because of a side effect. So when you compare, even if your benefit had been only 40%, when you compare the risk and the damage and the side effects as being zero, this is clearly a superior way to treat this type of problem from a cost.
Directly where the problem is. So the reality of it is there is no proven hypothesis for a central mechanism of neuropathic pain. So why would you treat the brain with an anti-epileptic pill when it's not the therapeutic area? The damage is to the peripheral nerves, and these are where we should direct the cause because that's where the possible mechanism. Sure, there's wind-up, but they're putting the pain pill, and they tell people, oh, it's going to go to the nerves in your feet, but it goes to your brain. Okay, so they've been trying to stick anti-epileptic pills in people since the very beginning. Doc, you could just name off a couple of these that people might recognize.
Well, yes, our first generation, when you say anti-epileptic, I think people mostly recognize that as seizure. These are seizure pills, okay? And carbamazepine is known as Tegretol. Clonazepam is one of the benzodiazepams related to Valium. Phenytoin is also known as Dilantin. Valproic acid is known as Valproic. It's pretty much how it's prescribed.
Now, Doc, those
first generation, these are seizure pills,
and they fell out of favor. Why? Why did they move to the second generation?
Well, primarily because they didn't work and they had a very high side effect profile. For example, like Dilantin and Tegretol, you have to do laboratory tests. You have to do blood tests and liver tests. It can damage your liver, your kidneys, and all sorts of things. So
they were highly toxic. How about this next generation?
The next generation were a little bit less toxic. For example, routine blood monitoring wasn't required. They didn't damage your liver, your kidney, and so forth. So they were a little bit better in that regard, but they still came with, as you've already described today, their own set of side effects.
So we would have the gabapentin, which would be your both that and Neurontin.
That would be the Neurontin. The lamotrigine is something known as Lamictal. Pregabalin is the Lyrica. Tiagabine is a newer medication, and Topamax is Topamax. And anyway, these are some of the newer medications that are being used.
But the problem is that it's under-recognized and diagnosed, and so the nociceptive pain, which comes from tissue damage of other tissues, gets confused with neuropathic pain, which is caused because damage to the nervous system. So they treat arthritis, right, like it's neuropathic pain, or they treat neuropathy like it's arthritis. They don't follow the plan because there's a lot of different causes of neuropathic pain, right? And that can be confusing too. They don't follow the connection. So you can have other disease process, therapeutic process, genetic process, trauma process that all look the same, but they all look different because there's different doctors that are prescribing it, right, Doc? You're going to go to a dermatologist, he can say, "Oh, that's neuropathy," you know?
Yeah. What's interesting is that you have the 7 blind men of India not examining one elephant, but 7 different elephants. So you got pretty much 49 blind men examining 7 different elephants of different colors. So in other words, you've got all those various sources of possible pain, and then they put them through this circus and these hoops. I think hoops is that's a great diagram because that's what a patient feels, that they have to jump through hoops. Well, I went to the primary care doc, says, "You got some kind of pain, you better go see the rheumatologist." And the rheumatologist says, "Oh, it's not your joints, it's your nerves. Go see the neurologist." And he does a few tests. "Oh, I think your hormones are out of whack. See the endocrinologist." And then And somewhere along the line, somebody's surely going to say it's all in your head and there's nothing we can do about it, so you need to see a shrink. Yeah. So you go see the psychiatrist. So you have all these different people looking at all these different sources of pain. Is it any wonder that nobody knows what the heck they're doing?
But that helps them because the PCP, the primary care physician, is a heavy neuropathic pain market and relatively untapped. So it's good for them because guess what? No matter what the pain is, they're going to throw one of those pills at you, right? But
well, that's true. And as a previous member of the primary care doctor population, I can tell you that the big pharmaceutical companies came to us as we were the so-called gatekeepers. In other words, in a lot of HMO plans and certain PPO plans, you couldn't see any of these other people unless you saw a primary care doc. And so therefore, guess who became the targets of big pharma? There was a period of time when it was allowed that I got wined and dined and flown all over the country and taken to golf courses and meals and all sorts of things to prescribe there. There's no end to what they'll go to get you to prescribe it. So the PCP market is heavily targeted by big pharma.
And the reality, neuropathic pain patients are still in pain. And they're in pain that doesn't stop, and they're in pain even if they give you the pill. And it's tough for these people who pain descriptors vary between patients and don't reliably reveal the problem or the etiology. So doesn't really matter. They're just going to get a pill no matter what. And so I think that what we wanted to do is show just a little bit of what sort of what's going to happen to a regular patient, a regular person who tries to walk through this medical model, the big business model of taking care of people's pain. I want to thank everybody for their participation today. And any closing comments?
I want to just say, I have some good friends that are primary care physicians and endocrinologists, some neurologists here in Atlanta. And when they see Miss Jones coming in on the sheet that day who has neuropathy, they cringe because nothing is working. And they hate it. The body builds a tolerance. So they might start off with 300 milligrams of gabapentin or Neurontin and 3 times a day, and then they have to move up to 600 and 900, and then they're at 1,200 milligrams 3 times a day. They're basically putting these people in a walking induced coma because it really affects them in a big way, and they're already predisposed to falling. So you put those meds in there with them, and it's definitely an issue.
Can I just mention at the same time that while you take a pill that goes to your brain so that you don't hear it, their nerve damage continues with nobody doing anything to help the nerve damage. Their drugs go up because their damage goes up.
Well, and that would be my final comment is that number one is that the pills are not really addressing the underlying pathophysiology. That is why, where is the pain coming from and why is the pain? All of these medications are nothing more, to the little bit they do work, they serve as nothing more than a Band-Aid. Whereas this closing image that you have, and I know you're going to be talking about it in your future webinars, is the non-pharmacologic treatment that the Neuropathy Treatment Centers of America have been so successful. And this, again, going back to the fundamental choice of the cost-benefit ratio. The cost of this intervention is very small, and the benefit is very high. And the side effects are zero side effects, and a 56% reduction in pain. I mean, that's quite impressive for having no adverse events. And this, in my opinion, is the only humane and reasonable way to go about treating peripheral neuropathies.
And if I could finish and just say, even though neuropathy is a nerve issue, we've said this on previous webinars, it is really an ischemic issue. It is lack of blood flow in certain parts of the area, especially the distal portions. And the beautiful thing about our pads and these polychromatic lights is that we can target the areas that are starving for oxygen, and we can place them in different areas. I want to thank Dr. Joe for allowing me to be the sideline reporter today. And Dr. Greg, it's always a pleasure to get your take on this. And we hope that more medical doctors start seeing the light and start coming over to our side. So thank you so much, Dr. Greg. And I know you've got some good things coming down the line that we're really excited about in that white paper. So that should be our next webinar as well.
Thank you, Dr. Matt and Dr. Joe. It's been a pleasure visiting with you.
Thanks a bunch, guys.